Hello everyone, good morning. Now we are going to see the last part of the introduction of Skynac. That is what we are going to see uh, from the what we have reached over here. That is in the postnatal part. That what I already explained. That the OPS is consist of the antenatal, intranatal, and the postnatal. In that postnatal, we are going to see about the this part, neonatal abnormal part. In previous lecture, and in number 9, we have seen about the postnatal, that is the time after the delivery. We have seen the normal, what is the physiology of characteristics of normal neonate. Now, in this session, what we are going to see, what is the abnormal part. So, OPS in that postnatal, that is related with that after the delivery, and neonate, and what we are going to see the what are the problems which comes it. That is the abnormalities we are going to see it. So, in previous lecture, what we have seen that the weight of the newborn should be 2.5 kg. So, there may be problems in the weight. There may be some problem in the for the normal respiration. There may be some. Sometimes it may happen that the meconium it is get aspirated. That can, or sometimes there is a jaundice. Jaundice can be there. So these are the some, or sometimes there is a injury to the newborn after the delivery, that is called as the birth injuries. So these are the points that what we are going to say in this lecture. So first, what we are going to say about the birth weight. So first, that is what is the normal weight. That is, it should be more than 2.5 kg to 3.1. So it's first weight of the fetus of newborn. It is obtained after birth, and why it is we are giving the importance to this. So importance of birth weight, that is it is the single most important determinant which will helpful for us for the survival and what is the growth and development of the this newborn, and what is it reflects what is the health status of the mother during the adolescence and the pregnancy, and also the quality of the antenatal care. So if you see the normal weight of the newborn, it is what we are seeing. It is 2.5 kg and more than that. And if the weight of the, that is LBW, low birth weight, what it signifies is if the weight it is less than 2.5 kg within 1 hour of birth, whatever may be the gestational age. So there are again variations. That is what we see that this is the in diagram, that is intrauterine growth chart. What we see here, it is the term delivery, that is the delivery which takes place from 37 to 42 weeks, then post-term, that is from 32 to 45 weeks, and the preterm, that is the before the 28 afterwards before the 37 weeks. So what we see that it is the, this is called as a if it is 90%, then it is large for dead fetus, and if it is this one, then it is the average weight, and if it is the less than that, that is called as a small for dead of the fetus. If it is 10%, so if this, and if this is in between this, that is the appropriate for dead. That is what we know. So if you see that again, this low birth weight, it is graded into three parts. That is one, low birth weight. Second, it is very low birth weight, and third, that is extremely low birth weight. And how much? That is if it is from the weight, it is from 2,500 to 2,000 gram, then it is low birth weight. If it is ranges between 1,000 to 2,000, then it is gram, then it is very low birth weight. And if the weight it is very less than the 1,000 gram, it is called as an extremely low birth weight. So that is from it. Again, this LBW, that is the low birth weight, it is on the basis of origin. It is divided into two parts, that is preterm, and second one that is called as the small for death, or intra-IUGR, that is intrauterine growth retardation. What is meaning of if the weight it is if it has completed 30, if it is less than 37 completed weeks of gestation, that is called preterm, and its account about how much, one-third of the total LBW. That is low birth weight. Low birth weight. While in case of small for dead fetus, so if it is 10 percentile for the gestational age, less than 10 percentile for the gestational age, and account for about two-thirds of low birth weight neonates. So maximum what we see from the small for dead fetus or IUGR stand for intrauterine growth retardation, that is NTW. So what is it? Low birth weight includes two groups, that is preterm babies and the IUGR. Whatever that 50% cases of the LBW, that is what we know that is the cause. If you want to find out, there is a unknown cause. But the remaining 50% of the cases, that what we see that it may be some problem related with the medical problem or the social problem. To see the hand of the person, normal person, how much is the weight, very low weight of this neonate. So that is how it looks like. And some medical causes, it may be problem to the mother, or it may be social causes, or it may be placenta, or it may be fetus. So whatever the maternal causes, that is all high risk mothers except diabetes comes in this, or if there is a problem to the placenta, which problems can occur. There may be placenta previa. What is meaning of placenta previa? That is placenta, it is attached in the lower uterine segment. If it is present in the lower uterine segment, or there are 4 degrees, that is lateral, marginal, when os is completely closed and os is completely open, that is degrees of the placenta previa, and congenital defects of placenta can be there. And you know that the placenta normally it is present in the upper uterine segment and posterior wall. Sometimes there may be medical cause, that is the fetal cause. What are the fetal cause which can be responsible for this? So there may be multiple gestation, that is twins may be there or more than that, or if there is a hydramnios or polyhydramnios, where the amniotic fluid it is more than 2000 ml or 2 liter. Hydramnios and polyhydramnios, it is a simple. Or if there is some infection during the pregnancy, that is intrauterine infection. In this, the mother it is smoking, that is what it is shown. Then social causes, sometimes poverty, illiteracy, then ignorance, not taking care properly, diet is not taken care taken properly by the pregnant mother during the pregnancy. Then poor standard of living and lack of knowledge of family planning. And sometimes it may happen that the mother is not that much of knowledge, or if it is the, or if her age is very less small as compared to normal, that is early marriages. And sometimes smoking can lead to this type of the problem, that is LBW. Now, LBW preterm, what are the problems it produces? It may produces birth asphyxia, that is temperature is also less of the newborn. Then there may be problem in the feeding difficulty. Whatever newborn is not able to suck the breast, or sometimes there is infection, hyperbilirubinemia, or sometimes respiratory distress is there, or retinopathy of prematurity, or acne cells, and intraventricular hemorrhage, hypoglycemia, metabolic acidosis. These are the common problems which can be present in preterm. While in small for dead fetus, LBW presented in the form of problems like birth asphyxia or meconium aspiration syndrome, that what we are going to see in the next. Hypothermia, everything less, that is hypothermia, hypoglycemia, infection, polycythemia. So these are the problems for the LBW. And now next, what we are seeing, that is asphyxia neonatorum. This one. So what is next? We are going to see about the asphyxia neonatorum. What is it? So what is it? After the birth, the neonate immediately start, the baby starts to climb. And what is it? It is the respiratory gaseous exchange which takes place. So when there is any impairment in this respiratory gas exchange, which is accompanied by the development of acidosis, then it is called as a asphyxia neonatorum. So if you see the introduction part of it, so birth asphyxia can be defined as a clinical condition which is characterized by inability or failure to initiate the normal, initiate, not only initiate or sustained spontaneous regular respiration. And what it leads to? It leads to various degrees of the hypoxia, or sometimes or and ischemic injuries to body tissues and the organs of the neonate. And historically categorized, it is divided into two. That is, it is called as a blue asphyxia, and the second one is white and pale asphyxia. So, what is asphyxia livida and asphyxia pallida? What is meaning of it? So in the asphyxia livida, that is blue asphyxia, whatever the skin of the newborn, it is looks like everything. It is the blue color that we are seeing here, and muscles, whatever the tone of the muscle is not good, and whatever if you give the stimuli to the infant, it does not give the normal response to the stimuli. So that is called as a blue asphyxia. And what is asphyxia pallida? That is called as a white and pale asphyxia. It is more severe as compared to the previous one, that is blue asphyxia, where the baby is looking very pale and flaccid, that is does not give the response to the stimuli. That is meaning of the asphyxia pallida. So according to the WHO, it is a failure to initiate and sustain the breathing at birth. Then NNF, that is again divided into two varieties: moderate varieties and the severe varieties. What is moderate asphyxia? What is it? Is slow gasping breathing or an APGAR score of 4 to 6 at 1 minute of age. This is founded by the person APGAR. What we are going to see in detail, what is the how is the scoring we are going to do it, and what is the meaning of this APGAR, we are going to see in the next slides. Then severe, just remember over here, that is the moderate one and the severe one. Moderate, that is when it is the APGAR score, it's from 4 to 6, and the severe, when there is a APGAR score, it is the 0 to 3. What happened in this? There is a slow gasping breathing is there, and in case of severe asphyxia, there is no breathing. And when it is taken within 1 minute of 1 minute of age. That is the criteria that what we follow. Then currently birth asphyxia is graded into three categories now. That is again, it is mild, moderate, and severe. See, in previously it is just moderate and severe, but now it is divided into three: mild, moderate, and severe. So according to the American College of Obstetrician and Gynecologists and the American Academy of Pediatrics, a neonate is labeled to be asphyxiated if the following conditions are satisfied. So what is the criteria they follow? That umbilical cord arterial pH, it should be less than 7. Then APGAR score, it is from 0 to 3 or for longer than 5 minutes. How much time it is? 5 minutes. In previously, it is about 1 minute. See over here, it is 1 minute. But according to American standard, the College of Obstetrician and Gynecologists says that it is up to the means longer than the 5 minutes. Then neonatal neurological manifestations, example seizures, coma, and hypotonia, and the multisystem organ dysfunctions like that of the cardiovascular, gastrointestinal, hematological, pulmonary, or the renal systems are get affected in the after this one, currently asphyxia neonatal. So what is it? It is a neonatal. What is APGAR? What we are discussing over here? That is whatever this criteria of asphyxia, mild, moderate, severe. It is depending upon something. This APGAR score. So what is this? So if we say APGAR, that is it is a neonatal evaluation and resuscitation. What it consists of? So APGAR, that is consists of A for appearance, P for pulse, G for grimace, A for activity, and R for respiration. And what we have to take it, this we have to take this all the characteristics of above, that is appearance, pulse, grimace, activity, and respiration at 1 minute and 5 minutes. What is see this? That is what we are saying: this respiration, crying, reflexes, irritability, pulse, heart rate, or skin color of the body, and the extremities and the muscle pain. That is what we are going to see in the after. If you see, depending the how much on this vertical lines, there is some this nomenclature that appearance, pulse, grimace, activity, and respiration. And on the this horizontal line, that is 40, 41, 40. That is if full pink color baby, then full it is 4. If the central part it is the pink and the peripheral it is blue, then it is 1. If it is totally blue, then 0 score. Then if pulse more than 100, then it is the per minute. Then uh, it is 2 marks. If less than 100, then 1. And if no pulse, 0. Then grimace, that is the cries and pulls away, then it is 2. If grimaces or just weak cry, there is not that much. In this one is a total loud noise what we are able to see. But here this is very weak, we are not able to fall properly. And if no response to stimulation, 0. Then activity. So this is the active movement of the hand which is taking place. Then 2 marks. If it is the arms and legs are flexed, but not that much of activity as compared to this, then 1 mark. And if no movement at all, then it is the limping is there, then we can think about the 0. And respiration. Definitely the cry is respiration. If strong cry is there, then 2. If slow and irregular cry, then 1. And if no breathing, then 0. So that is how the score it is calculated. Now we are going to see how does the APGAR score work. So the APGAR scoring system is divided into 5 categories. That is, each category receives a score from 0 to 2 or 2 to 0. We can say that. At most, a child will receive an overall maximum. How much maximum marks? Definitely, it is just 2 plus 2 plus 2 plus 2 plus 2. It is 10 marks. And how much minimum? That is 0. So how much range? It is 0 to 10. That is maximum. So at most, a child will receive an overall score that is 10, not more than 10. So, however, a baby rarely scores a 10 in the first few moments of life. This is because most babies have blue hands or feet immediately after the birth. So, don't let, so if there is a situation that the upper score it is 11 and 12. No, it is maximum, it is 10, minimum, it is 0. For example, if you can take his heart rate, if the heart rate is absent, then you can score 0. If it is the slow heartbeat, that is less than 100 beats per minute, then 1. And if it is the adequate heartbeat, that is more than 100, then we can 100 beats per minute, then we can score 2. So 2, that indicates a good strong heartbeat. 1, that is slow but steady heartbeat. And 0, no, that is little or no heartbeat. That's how much scoring we are going to give it. So APGAR score. Now, if we calculate it, then what it indicates? If the APGAR score it is from 7 to 10 points, that indicates the newborn should be active and vigorous, and it's provide routine care. While in 4 to 6 points are there, the newborn is the newborn is moderately depressed and provide stimulation and the oxygen. While if the whatever this APGAR score last, what we see that over here, 0 to 15 points. What it indicates, the newborn is severely depressed and requires the extensive resuscitation. That is how we are going to manage this, how we are going to take the help of this APGAR score for the further management. So then maximum total score, what we know that in APGAR score, it is the 10. So if it is 7 to 10, normal. If it is 5 to 6, that indicates it is a mild birth asphyxia. If it is from 3 to 4, it is a moderate birth asphyxia. And if it is from 0 to 2, that is severe birth asphyxia. So whatever this neonatal mortality, why we are saying this? Because the cause for the neonatal mortality, so birth asphyxia is about some 29%, if infection 32%, then the complications of prematurity, that is what we are saying, this complication of prematurity is 24%, congenital anomalies it is 10%, and other it is about some 5%. So that is the problem with the mortality of neonatal. That is caused behind the neonatal. This is the pie chart of what we are going to see percentage wise. Now see in this is the normal neonate, what is characteristics, vigorous baby born at term, needing only routine care, just what we are used to the routine care. What we say is crying, the skin is pink color, appearance, there is no bluish one, that is then the active movement of the that can be present over here, if you can see it. But in this scene, what you see that baby with poor tone and the color who needs the resuscitation. So this is the difference what this Abgar store is going to help in. The hands what we are seeing it is over here it's bluish color. So this is bluish color. And over here it is the pink color all over. And good crying. But here we don't see the crying or active movement of the hands. Sometimes there may be perinatal asphyxia, that is a failure to initiate and sustain the breathing at birth. It again divided into slow gasping and the severe gasping. That is the slow gasping breathing or an APGAR score of 4 to 6 at 1 minute of age, and severe, that is no breathing or an APGAR score of 0 to 3 at 1 minute of age. So what are the clinical features of this asphyxia? It may be apnea or bradycardia. Then the altered respiratory pattern, that is the grunting and gasping. Sometimes cyanosis, that is bleed discoloration, which is present. Pallor and the shock and hypotonia. Tone of this skin is not that, which of body is not there. And unresponsiveness. That is the characteristic features what we are going to see in the asphyxia neonatorum. Then characteristics of the perinatal asphyxia, that is the profound metabolic acidosis, that is pH less than 7, is the persistence of an APGAR score of 0 to 3 beyond the 5 minutes, and what is clinical neurological sequelae in the immediate neonatal period, what we are going to see it. That is this associated with that of the neurological sequelae. And the evidence of multi-organ system dysfunction in the immediate neonatal period. So it is derived from the 1992 joint statement of the AAOP and ACOG and the 1999 International Cerebral Palsy Task Force. That's what they have found out. So what is the characteristics of perinatal asphyxia, that is around the time of delivery. Then there may be some situation that meconium it is get aspirated, and whatever the symptoms, group of symptoms we are going to present, that is the meconium aspiration syndrome. What is it? It is a respiratory distress. When in an infant born through the meconium stained amniotic fluid, whose symptoms cannot be otherwise explained. Otherwise, we cannot explain over here. So, what is the, if you see the physical examination, how it clinically sees that. So, on the evidence of post-maturity, that is after the 41 weeks of gestation, it is delivered. So, how is the skin, it is peeling, and the long fingernails are there, and the decrease the vernix is there. The vernix, umbilical cord, and the nails may be meconium stained. That is meconium which is present, which is stained. So depending upon how long the infant has been exposed in uterus, depending on that, the symptoms are going to be shown. But in general, nails will become stained after 6 hours and vernix after 12 to 14 hours of exposure. And the umbilical cord staining, that is, it is become thick to 15 mm thin, that is in 1 hour. Seedless, this is meconium stain in this umbilical cord stain with the meconium. That's what we are going to see. Then clinical, that is clinical features, physical examination. Affected patients typically have respiratory distress with that of marked tachypnea and the cyanosis, that is the skin become bluish in color, and use of accessory muscles of respirations are evidenced by the intercostal, because we know that the intercostal subcostal retractions is not, or abdominal paradoxical movements, that is indicates there is a accessory muscles. These are the accessory muscles of the respiration. So that would breathing what we are seeing often with that of grunting and the nasal flaring. In normal respiration, we don't see the nasal flaring patterns, but in case of this meconium aspiration, we are seeing the grunting and the nasal flaring, and use of this accessory muscles of the respiration. And in that situation, what we see that on physical examination, if you are going to see the clinical features of the test is typically of expansion. With that, what is the position, diameter, what we know that it is different. In that situation, whatever anterior posterior diameter, it is overinflated. So it looks like that of the barrel shape. And on auscultation, it reveals that is Ross and Ronchi, that is immediately after the birth. Some patients are asymptomatic at birth and asymptomatic at birth and develops worsening signs of respiratory distress as the meconiums moves from the large airways large into the lower tracheobronchial. That is what we see in this. So this is the meconium aspiration. That is how it is taken inside of it. Then meconium aspiration syndrome, that is meconium, it is this is the uterine wall, the meconium, it is get inside of it. Here, meconium, it is getting inside of it. Here, the meconium, it gets into the trachea, it is windpipe, meconium, it is maybe in the lungs, can be go, depending upon the symptoms changes. So in this, the meconium, it goes inside of it. It is affecting the symptoms are shown. That is called as a meconium aspiration syndrome. Then sometimes there is a neonatal uh, hyperbilirubinemia. That is, what is it? See, it's normal newborn. It is pinkish color. But in over here, that is the jaundice is the yellow color of the skin and the sclera caused by deposits of bilirubin. And when it is visible, that is, it is adult sclera, it is more than 2 mg per dl. And in newborn skin, it is if it is the more than 5 mg per dl. That is sclera. Then again, it is divided into two parts: physiological jaundice and the pathological jaundice. So it appears after 24 hours. The total bilirubin rises by less than 5 mg per dl. Maximum intensity, it is on the 4th and 5th day in terms, and the 7th day on the in case of preterm babies. While that of serum level less than 15 mg per day, and clinically it is not detectable after 14 days. It subsides. That is called as a physiological. While in case of pathological, it appears appears within 24. Remember, physiological never occurs within 24 hours. It occurs after 24. While that of pathological, immediately after the birth, maybe within 24 hours. It increase of bilirubin that is more than 5 mg per dl per day, and serum bilirubin more than 15 mg per dl. So whatever the jaundice persisting after 14 days. While in physiological, it does not persist after 14 days. While in pathological, here it does not persist after the 14 days. While here in pathological, it persists even after 14 days. And if you see that there is a changes in the stool also, so how it is clay color and white color. And urine staining, yellow staining clothes, that is direct bilirubin, it is more than 2 mg per dl. So it is physiological jaundice characteristics. What we say that it appears after 24 hours, the total bilirubin is less than 5 mg, maximum intensity it is on 4 to 6 day, and whatever the serum level is more than less than 15 mg per, and it is not seen after clinically after 14 days. This is the what is physiological jaundice in the newborn. Obviously, the increased bilirubin load, defective conjugation, and increased intrahepatic circulation. And if you see the incidence in the term, it is about 60%, and it is in the preterm, it is about 80%. So this is physiological jaundice. See the incidence wise in preterm. This one is physiological, not within this first day, no start. That is characteristics over here. Please note it. If it is started over here, that is pathological one. And this is started over after the 24 hours, and definitely it subsides within 14 days. starts over here, and then it is continuous, even after the this one, 15 days. So that is how it is. So this may be starting from this curve what I shown over here. So that can be pathological. So that is how this on the vertical line what we are seeing this bilirubin level, and this line what is we are seeing the age in days. So that is characteristics of the physiological jaundice. Then breast milk jaundice. So what is it? It is caused by prolonged increase enterohepatic circulation of bilirubin. Bilirubin peaks, that is PGD increases. Bilirubin peaks at 10 to 15 days of age. The level of unconjugated bilirubin is at 10 to 30 mg per dl. If nursing is interrupted for 24 hours, the bilirubin level falls quickly. So it can, if you stop the breastfeeding, it falls within immediate after 24 hours. So see, in breast milk jaundice is the commonest cause of prolonged jaundice in the term. So what we have to think about, stop the breastfeeding for 24 hours. It will subside. It falls quickly. So this is normal newborn and this is jaundice newborn. So this is pink color, this is yellow color that we see in the new jaundice. Then pathological jaundice, this is pathological jaundice which starts immediately after the 24 hours within, then bilirubin level more than 5 mg, serum bilirubin more than 5 mg per dl per day, serum bilirubin more than 15 mg per dl per day, 15 mg per dl, and it persists even after 14 days, and whatever the stool of the newborn, it is whitish or clay color, and whatever the urine, it is yellow staining the clothes, and direct bilirubin is more than 2 mg per dl. So it is pathological jaundice, that is unconjugated and conjugated. Unconjugated bilirubin again hemolytic and non-hemolytic. And conjugated, that is again divided into the hepatic and post-hepatic. So unconjugated indirect hyperbilirubinemia, that may be due to the hemolysis. That is, if there is a RH or ABO and other blood group incompatibilities, sometimes there may be seriocytosis, elliptocytosis, alpha thalassemia, or sepsis, or DIC, hematomas, or polycythemia. And non-hemolytic, that is breast milk jaundice, that is what we are seeing in the previous, this one, this breast milk jaundice. Krigler-Najjar syndrome type 1 and 2 Gilbert syndrome, that is the what we see there. So hemolytic disease of the newborn, that is is in isoimmunity hemolysis associated with that of RH incompatibility or ABO blood group problem. If you see in that, so it is first birth, mother RH, mother, red cells are present after delivery, RHB antibody, immune system, and then subsequent pregnancy. With RH antibody which are present in fetal RHB red cells can lead to this type of, that is called as erythroblast fetalis. Then we give the anti-D injection in the delivery, anti-D. So that is not given, it has to be given after the first delivery. So what we have to approach for this to jaundice baby, to determine the birth weight, gestation, and postnatal age, assess clinical condition, when or ill, degree of jaundice, and decide whether the jaundice is physiological or pathological. From the onset, we can decide whether it is physiological or pathological. And look for important, that is kernicterus. Kernicterus is deeply jaundice, that what we have to, jaundice LD that we have to see it. This is how the head to toe distribution of the jaundice. The clinical assessment of jaundice, that is area. If it is face, if it is the if it is present on the face, that is bilirubin level is 6. If it is in the upper trunk, that is 9. If it is in the lower trunk, that is 12. That is the lower trunk and thighs, that is the third area. That is the bilirubin level is 12. And if it is arms and lower legs, that is here and here, that is 4, that is bilirubin, it is 50. And if it is on the palms and sole, that indicates the bilirubin level, it is more than 15 dl per dl mg. So this is the what is leads to this. It is yellowing of the eyes, yellowing of the skin, excess bilirubin in the blood. Bilirubin moves from the bloodstream into the brain tissue, crosses the blood-brain barrier. It enters into the brain tissue. And what will lead to? If it is entered into the brain tissue, then there is a jaundice or yellowing of the eyes, or yellowing of the skin, or excess bilirubin in the blood. And in chronic cases, bilirubin moves from bloodstream into the brain tissue. So there is a yellow coloring of the baby skin, usually beginning of the face and moving down the body. That is poor feeding or lethargy is there. That may be the characteristically which is present over here. Then next what we are going to see, if this bilirubin level it is more than that, so what it leads to the kernicterus, that is bilirubin encephalopathy. Bilirubin encephalopathy. So this is major clinical feature of acute bilirubin encephalopathy, that is lethargy, poor sucking, poor or absent morals, retropolis, apostolic convergence. This is called as apostolic deficiency. Neck it is extended, chest it is forward. So that is apostolic position, encephalopathy. So this infant presented at age of 30 days with a serum bilirubin level is 30 mg per day. And secondary to tracheal Naegeli syndrome, type 1, he demonstrates retropolis and apostolic signs of the intermediate to advanced stage of acute bilirubin encephalopathy. So this is the curve. Neck it is extended curve which takes place. Now, last part, what we are going to see, that is the birth. Birth injuries, we are going to see it. Before that, what we are able to see in the respiratory, there is some sound that is you see that so how this if it is in case of asphyxia neonatorum, so clinically we have to gasping or signs which are present. So how it sounds like this. So that is the sound which is present. Now, next what we are going these are the sounds which is present. Then last part, that is the birth injuries, what we are going to see. Birth injuries. So that is, there is a difference between birth injuries and birth injuries to canal. So birth injuries to canal, that is related with that of the mother, while birth injury that is related with that of the neonate. So what it leads to? So it is an impairment of the infant's body function or structure due to some adverse influence that occur at birth. So it may be injuries to the infant may result from some mechanical forces that if you are applying it, that is compression or traction during the birth process, which is responsible for it. Then it is the classification of it. So depending upon which part it is affecting. So if it is affecting soft tissue, then it is soft tissue injuries. If it is affecting head and neck injury, head and neck, then head and neck injuries, then facial injuries, then sometimes it affects the nerves, then cranial nerve injuries, spinal cord injuries, peripheral nerve injury, fracture, that is torticollis, or intra-abdominal injury, whatever may be. So these are the different injuries which can take place from soft part to heart to nerves, anything. So that is the different varieties of injuries which can take place to the birth. This is classification of the birth injuries to the newborn. So it is soft tissue that may be present abrasion, erythema, petechia, ecchymosis, laceration, subcutaneous fat necrosis. And in skull, there may be presence of caput subsidianum and cephalohematoma. What is it? What we are going to say? Or subgaleal hemorrhage, linear fracture, intracranial hemorrhage, and number of this. But just to just remember, these are the basic things that is the caput subsidianum and cephalohematoma. On the face, that is subconjunctival hemorrhage, retinal hemorrhage, cranial nerve and spinal cord injuries, facial palsy, then peripheral nerves. It can be affected centrally in the or peripheral. On peripheral, there is a brachial plexus palsy, unilateral vocal cord paralysis, radial nerve palsy, lumbosacral plexus injury. Musculoskeletal injuries leads to the clavicular fracture, fractures of long bones, sternocleidomastoid injury, and in intra-abdominal injuries, that is liver hematoma, everything hematoma, and hemorrhage. So it may be liver hematoma, splenic hematoma, or adrenal hemorrhage, or renal hemorrhage. But what we are going to concentrate on this caput subsidianum and cephalohematoma. So soft tissue, that is abrasion, erythema, petechia, ecchymosis, laceration, and subcutaneous fat necrosis. So this is abrasion and laceration. See, abrasion. This is abrasion, this is laceration. So it may occur as a scalpel cuts during the cesarean delivery or during the instrumental delivery, that is pactal and forced delivery. Or infection remains a risk, but most uneventually, it eventually heals on it. And we have to take the proper management of this careful cleaning and proper application of antibiotic and observation. Laceration occasionally requires, if laceration is present, then what we require the suturing is required. Then subcutaneous fat necrosis may be there, and it may be some what we say here, it is the subcutaneous fat necrosis. So it is irregular, hard, non-pitting subcutaneous induration with overlying dusky and red-purple discoloration on the extremities, face, trunk, or buttocks. It may be present anywhere. It is maybe caused by the pressure during the delivery. Why this is occurring? Due to the pressure during the delivery. And it is no treatment for this required. It is subcutaneous fat necrosis. Sometimes it's calcified. Sometimes. Then skull injury, that is most important. That's what we are going to say. The caput subsidianum and cephalohematoma. Then others like the subgaleal hemorrhage, skull fracture, linear depressed, and infernal hemorrhage. Maybe there. A caput subsidianum. What is caput subsidianum? A caput subsidianum is an edematous swelling which forms normally in the soft tissue over the presenting part of the skull due to infiltration of serosanguineous fluid by the pressure of girdle of contact. So what is it? It is a edematous swelling. This is what is difference. Caput, it is upside, and cephalo, it is downside. It does cephalohematoma does not cross the suture line, and caput can cross the suture line. This is the suture line. It crosses the suture line. So this is the skin. Then what is the gallia or the epicranial aponeurosis, periosteum. This is the skull which is present, and this is durameter. And this is the hemorrhage that is called as the extradural hemorrhage. This is subgaleal hemorrhage. But what is we are concentrating on? Caput and cephalohematoma. So it is a mechanism of formation. Why it is occurs? It occurs due to the compression of tissue in the girdle of contact, which results interference of the venous return and lymphatic drainage from the unsupported area of skull that causes stagnation of fluid and appearance of swelling in the skull. That is called as a caput. See how the during the delivery, if this is the force which is present over here, so it leads like a shiva. See this thing. So this is what we see there. Again, in the movie also we see this type of thing. If delivery has taken place, that thing, then what is such type of shape it is there, that is called as a shiva. And clinical features, it is present at or shortly after the birth and does not tend to enlarge. And caput, we can remember cap. So it is shaped like cap. See. So it represents at or shortly after birth and does not tend to enlarge. The swelling is diffuse, boggy, fits on pressure, and may cross suture line. It definitely crosses the suture line. So in this diagram, it crosses the suture line. It crosses the suture line. And if you give the pressure over here, it gives the pressure. So what is it? It is the cap goes across the suture line. It is the boggy, edematous swelling of the fetal skull. It disappears without treatment and no pathological significance. Mind it. This is the example of subsidiary edema of the presented part caused by pressure during the vaginal delivery. This is the serosanguineous subcutaneous extraperiosteal fluid collection with poorly defined margin, non-fluctuating. And if you see just giving the pressure, this is repeating. So that is it. Now, cephalohematoma. Hematoma stands for collection of the blood. And so what is it? It is a subperiosteal collection of blood, where it is in the pericranium and periosteum and the flat bone of the skull, usually unilateral and over a parietal bone. That is what we see over here. Bone, bony part, and it is skinny. It does not cross the suture line. So this is practically how it looks like. So this is cephalohematoma. It is subperiosteal collection of blood within the skull and periosteum. It may be unilateral or bilateral and appears within hours of delivery as a soft structure swelling on the side of the, on the parietal bone. That's what we see there. And a cephalohematoma never extends beyond the edges of the bone or cross the suture lines. It does not cross the suture line. It is on the parietal bone. Yes. Okay, then causes, it is due to the rupture of a small vein from the skull that may be from friction between the bones of maternal pelvis and the fetal skull as in cephalopelvic disproportion or CPD, that is what we have seen, cephalopelvic disproportion. If the head of the fetus is large or the shape of the female pelvis is not proper, not gynecologist can lead to this. Or precipitate labor or complicated or forceps delivery, but may also this thing following normal delivery and may be associated with fracture of the skull bone. And clinically, the swelling is usually never at birth. It gradually develops a few hours after birth and may persist for weeks, 2 months or long duration. And it is circumscribed, incompressible, and never crosses the suture line. So this is cephalohematoma, practically how it looks like. This. It does not cross the suture line. Volume capillary, it's like a cap-like structure. The overlying scalp may show discoloration. The condition may be confused with caput subsidianum or meningocele. Meningocele lies over a suture line or fontanelle, and there is an impulse on crying. So this rarely suppuration occurs. This is how it looks on the cephalohematoma on the X-ray of the girl. Cranial X-ray. So this is that is cephalohematoma. How this is the clinical difference between it crosses the suture line, it does not cross the suture line. Then caput succedanum, its condition marked by the localized topicudinal with poorly defined outline, where it is a condition marked by soft fluctuant localized swelling with well-defined outline. It is caused by pressure of the fetal head against the cervix during labor, which decreases blood flow to the area and results in edema. It is caused by subperiosteal hemorrhage. Timing, when it appears. This appears present at birth but does not increase in size, while it appears after birth but increases in size for 2 to 3 days. Swelling crosses the suture line. It does not cross the suture line. See, it crosses the suture line. Blue line is present over here. But in hematoma, it does not cross the suture line. It disappears after birth within a few hours to several days. It disappears from several weeks to even months after birth. Complications are rare. Here, complications include defective blood clotting, underlying skull fracture, or intracranial bleeding, and jaundice. Or sometimes there is an injury to the brachial plexus, so it can be the earth palsy. That is what you say that earth palsy. So the most common lack of shoulder motion and the involved extremity lies adducted, prone, and internally rotated. How you see this is the internally rotated. It is morobiceps and radial reflexes are absent, and on the affected side, grasp reflex is usually present. Earth palsy may be associated with injury to the front nerve innervated with fibers from C3, C5. See, this is the hand which is present in Earth palsy. This may be present with an asymmetric posture of the arms. The left arm is not flexed and hangs in limbly adduction and internal rotation of the arm with pronation of the forearm. See this here. Biceps reflexes are absent, motor reflexes are absent, grasp reflex is present. The involved arm is held in the veter stiff, that is veter stiff position with adduction and internal rotation of the shoulder, extension of the elbow, pronation of the forearm, and flexion of the wrist and fingers. The baby demonstrates the findings of the left-sided of paralysis. This is left-sided of paralysis. So that is in short what we have seen in today's lecture. That is about the what is the problem that may be low birth weight and types of the low birth weight. Then what we have seen the Asphyxia Neonatorum, then Napoleon aspiration, then Neonatal Jaundice. In Asphyxia Neonatorum, what is observed for the birth injuries? Birth injuries again, that is what is static subsidiary and encephalomatomy and Erb's palsy. So these are the that is last part what we are seeing. What is the abnormalities to the problem to the neonate which can be explained. If any questions, please let me know. And the most important, thank you very much.